Hello and welcome. I'm Carrie Hopkins-Isles. I'm the Deputy Director for ICUDDR, and we're so glad that you're here today. We're really excited for this topic, this really important tool that I think you will all benefit from hearing about. And we're also excited because so much of what we value at ICUDDR is in collaboration, and this collaboration was, you'll hear, born from a lot of work. And today, we're collaborating to have our partners at ISSUP as well as at ISAM to bring this webinar to all of you. If your university is not a member of ICUDDR yet, please join us. It's very easy to do and free. You can go to our website, ICUDDR.org, or if you have, I'll also put that in the chat if you have any questions. And now I'm going to turn it over to my dear friend and partner at ISSUP, Livia.
Thank you very much, Carrie. And yes, I'm Livia Edegger, and I'm the Deputy Director of ISAP, the International Society of Substance Use Professionals. And on behalf of ISAP, I would like to welcome you all to today's webinar, and just echoing basically Carrie's words, we're extremely grateful for this exciting collaboration between ICUDDR, ISAM, and ISAP, and I would like to especially thank today's presenters for the excellent work in creating the tool, and we're very excited to be able to share such a practical, easy-to-use tool that summarizes best practices with you all today. And I'm going to do similar to Carrie. For those of you who do not know ISAP, we're an international organization with over 28,000 members who work in prevention, treatment, and recovery support around the world. And like Carrie said, also are a membership organization. So if you would like to join ISAP, if you haven't already, you can apply for free membership through our website at www.isap.net. And I'll also put that into the chat. And before we get started, I would like to share a couple of logistical things with you. At the end of today's presentation, there will be a short Q&A session moderated by Carrie. So you may send in your questions at any time during the presentation through the chat function on the GoToWebinar control panel. And we're also pleased to announce that today's webinar is not only available in English, but also in Spanish and Russian. And please follow the instructions in the GoToWebinar chat to access the webinar in Russian and Spanish. I will briefly welcome our Spanish-speaking attendees and provide them with the info to access the Spanish interpretation. Unfortunately, I don't speak Russian, so hopefully the instructions are clear to our Russian-speaking attendees. Hola a todas y todos y bienvenidos. Me alegra mucho anunciar que el webinar de hoy está disponible en español y pueden encontrar las instrucciones para tener acceso a la interpretación en el GoToWebinar chat. Y pues espero que les sea muy útil el contenido que comparten los expertos en el webinar de hoy. Yes, and you will all receive a follow-up email after the webinar with a certificate and a link to view the recording of today's webinar. The webinar will also be available on our website and on our YouTube channel. And now it's back to you, Carrie.
Thank you, Olivia. Livia, impressive as always. And we have a really impressive group today. I love how Livia pointed out that this is a really practical tool, and I think that's why I'm so excited for the presentation and the work and to disseminate this tool. So enough from us. I'm going to turn it over to Alex, and we appreciate you.
Hello, thank you, Carrie. Thank you, Olivia. And I think I should start by, continuing that collaboration. I'm here on behalf of the International Society of Addiction Medicine, and again, another global organization that has addiction medicine at its core mission. And essentially, with organizations like ISAP, ICUDDR, and other global organizations, what we do is we try to, encourage people to learn more, improve the competency, which would ultimately improve the care that we deliver as practitioners. I'm going to start by reflecting a wee bit around, what we're going to present as a tool within a global context. And, this webinar, this tool is it's been worked and discussed for the last year or so, if not more. But it's timely now because only recently the World Health Organization, through the 75th World Health Assembly, have agreed and adopted the Global Alcohol Action Plan. This is unique. I do not remember having such an opportunity in my professional life to do something around alcohol use disorder, to support people who have problems as a result of alcohol use and abuse. And within this Global Alcohol Action Plan, there is a promise that the global communities will engage in order to support a 10-year plan to try and mobilize the skills, the competencies, the infrastructure that there is right now in order to reduce the mortality and the morbidity again as a result of alcohol use. And this tool is, I said, timely, but also fits very, very, very well in one of the 7 main domains of the Global Alcohol Action Plan. And that includes the providing within the implementation of high impact strategies, and I'm going to read it here, providing universal access to affordable treatment and care for people with alcohol use disorder and interventions for hazardous alcohol use. You would think that there is universal care and universal access, and we all know there isn't. You would think that there is free care and free access, and we know it doesn't exist. So in a way, the work that has been and will be presented now is one of those where through collaboration, through meaningful collaboration, we can do so many wonderful things. But not for us, not just for us, feeling good about ourselves. But it's more around saving lives. I think that's the essence of it all. It's supporting communities, supporting families, supporting individuals. And this tool will save lives. And one cannot stress the power behind, providing evidence-based documents like this that is practical and with a global audience in mind. And with that, I will hand over to Audra, I think.
Thank you, Alex, and hello, everyone. It's so wonderful to be on this panel today and to be speaking to all of you. And I'm just going to share for a few minutes the story of this tool and how it came to be. It's not too far off in distant memory when COVID was beginning to be a new and scary thing. And I was working in a clinic here in Landstuhl, Germany for the Army. And my colleague, who was an addiction-trained psychiatrist, and I were beginning to get concerned about services shutting down, people being in isolation, our service members and other clients increasing their alcohol use. And we were already having problems with individuals coming to an emergency room setting or family practice setting with alcohol-related withdrawal or alcohol use disorders and not getting evidence-based treatment. Not because the providers didn't want to give that, but they didn't feel comfortable in addressing it directly, or they didn't know how to. So we have this wave of COVID coming, a concern about the ability to provide evidence-based care for alcohol use issues. We have a concern about our staff being pulled out of the daily mission to help with the COVID mission or getting ill. Higher levels of care were shutting down, groups were getting canceled, virtual connectivity was an option, but kind of spotty. And we wanted to be able to develop a tool or almost like a handout to give to anybody in like a frontline medical situation to say, if you see alcohol withdrawal, here's the must-dos. Just do this and you'll be able to resolve the crisis and get the person connected to care. So we started searching for this kind of first aid for alcohol use disorder and alcohol withdrawal symptoms and couldn't find a simple practical tool. So next question was, is it even possible to develop one? We wrote an SOP, a standard operating procedure for our clinic to try and have that kind of approach, shared it with Big Army, who said, wow, this is great. Nothing like this exists in big Army medical world, and they shared it worldwide. So that was some of the background of how this idea originated, at least from my side of things. And then I started thinking, well, if this is a big concern for a big system like the Army that's well funded and has all these great providers, then it must also be a big issue for other systems. And I started having conversations with my old employer and colleagues, and because I used to work for SAMHSA, and I used to work in nonprofit community mental health settings, and was like, well, if this was a gap here, it's probably a gap there, and what's the opportunity? So a couple people started introducing me to more people, and we started having more conversations, and I got introduced to ICUDDR and was already a member of ISSUP, and then got introduced to Alex. And then I got introduced to Darius. Then I got introduced to Moses, who's not on this panel, but he's listed on as one of the contributors. He's a wonderful physician leader out of Nigeria who was a great contributor to this tool. And then Linda and I had already had a pre-existing professional relationship that got reconnected. And then we started collaborating and volunteering our time to develop something that would be a tool that would fit into a global practice setting, that could be adapted and used to fit anywhere to help assess and treat alcohol withdrawal. What we discovered is trying to take something that's a complex topic and has so many variations, and there are lots of different documents and clinical practice guidelines out there addressing this, but taking all that information and simplifying it into the must-dos and some recommended practices became such an incredibly meaningful challenge for us. But then ultimately over time, meeting at 6 a.m. in the morning for some people, lunch hours, evenings, recalling that we're all just volunteering our time to do this because we also want to do this, we eventually focused in on this. And then got some help with Maureen Fitzgerald and Susan Eli to format it and make it pretty. And now here we are, trying to share it with all of you, to do the same thing that we did, which is to help have something that will be useful and meaningful and effective, and also to start conversations, just like we did, to start building your network, to start increasing and expanding and refining your capacity to assess and treat alcohol use withdrawal, and to connect individuals with ongoing care. So with that, this was one of the most meaningful things I've done professionally, and I had such a privilege of working with these talented, dedicated, wonderful professionals, and I hope that you get some use from it. So with that, I'm going to hand this over to Darius, who will be talking more about the actual tool, the science, and how to use it, and get back into that kind of practical approach. Darius, to you. Oh, I'm sorry.
It's okay. It's okay, Darius, if you could move the slides forward.
Linda is going to do this. And Linda, we have a few slides that Darius is going to show. So please, I'm handing this to my good colleague, Linda here. Linda, to you.
Thanks. Next slide. So we wanted to acknowledge contributors here, and what I really want to emphasize is the way this process mirrors what you're going to face at the local level. And what's really exciting about the work we've done as a group is that we represent exactly the kind of people that need to engage around this at the local level in the community. As a person who comes from a family in recovery, as a nurse who's worked in inpatient, outpatient, and academic settings, as someone who's lived in rural areas where we could not access the care needed for family and community members, this is a global issue. This is not, nobody's got a corner on the market of the need for services for alcohol use disorder. And so with that, wanted to give a broad overview of what's in the instrument before Darius does a walkthrough of what this looks like from a clinical perspective. Next slide. So we really tried hard to take the first year of work of what is evidence-based, what does the research say, and how could we make a tool that would be of assistance, and then turn it into something that's usable for community members, whether you're starting from the hospital or you're starting from your local community or your recovery community. And so the decision tool really does provide guidance for prescribing clinicians on managing clinical decisions related to alcohol withdrawal syndrome, for non-prescribing clinicians like Audra and myself, who really support and work with patients or work with building networks of care, for program managers, if you've ever served in that role, trying to make all the cogs work and make sure that they're oiled and that everybody has the resources they need. And how do you link in important resources at the family and community level to support patients? And last but not least, what can community members do to build treatment and recovery support at the local level? And I truly believe that this tool is something those of you in the academic setting can use to disseminate and share the importance of community-based movements to address gaps in service. Next slide, please. The other thing we've provided are some forms and templates that are at the very end of the tool. And again, this wasn't an effort. We know things have to be translated, things have to be formed to what is necessary for you in your setting and in your practice. But we wanted to provide some templates that would make it easier to figure out what you need in place, who needs to be at the table, how communication can work. So there's not only sort of a high level, how do you make a decision about whether outpatient services are doable and workable for a patient, to clinical protocols. How can you begin to articulate what your own protocols are in your practice setting? We also included validated screening tools that can be used. Again, you may need to translate, you may need to teach people how to use these tools, you may need to build your internal team and make a pathway for external network of services as you do all of this, but these are all here for you. I think they're, what's really nice is an example of what this can look like at the community level. Basic decision tree for how you deal with more acute high-risk patients who have chronic alcohol use. And then a template for you to make your own procedure. That particular form is something you can edit and tailor to what your needs are. So I think we've provided the basics that get the conversation going, but we'll reiterate again, this won't happen overnight, just like it took 2 years to go from a concept to a product, which we're excited to share with you. As you use this tool, we hope you'll give us feedback, share what your experience is so that people can learn from what works or what doesn't work across the globe. And with that, I'll turn it over to Darius to review the clinical components of the tool. Thanks.
Okay, thank you. So I'm going to review briefly some of the highlights of the clinical recommendations in this tool. And all of my slides are basically adapted from the tool itself. So this is all information that's available in the tool. So I think that most people are familiar with the signs and symptoms of alcohol withdrawal. We generally categorize them in sort of 3 categories: the mild symptoms, which include anxiety, tremor, restlessness; more moderate symptoms, which may progress to sweating, increased blood pressure, rapid heartbeat or breathing; and then severe, which is usually characterized by disorientation, agitation, hallucinations, and seizures. And so symptoms, tend to occur about 6 to 24 hours after the last drink. The mild symptoms initially, and then they can progress if not adequately treated. So when approaching a patient who has alcohol use disorder and wants to come off of alcohol, medications to help with withdrawal and support is the first step. And when thinking about that, we have to consider the setting in which this patient should be treated. So very often the initial decision is whether this person can be treated in an outpatient or ambulatory setting, or whether they need to be in an inpatient or more monitored setting. There are some models that are kind of in between, like a day hospital model where a person comes every day and they're monitored and then they go home at night. Since this tool is focusing on outpatient treatment, we really need to think of who is appropriate for that kind of treatment. So these are all sort of considerations which would make us lean towards inpatient treatment. So a history of alcohol withdrawal delirium or withdrawal seizures. So somebody who's had severe withdrawal in the past is at risk for having that again. And so they're probably more appropriate to be treated in a monitored setting. If they're actively psychotic or have severe cognitive impairment at the time of assessment, if they have co-occurring medical conditions that pose a serious risk, including heart disease, significant liver disease, if they're currently in severe alcohol withdrawal, and these can be assessed using validated instruments. If they're not able to take oral medication, if they have significant liver impairment, other medical conditions that can complicate withdrawal management, such as pregnancy, recurrent unsuccessful attempts at alcohol withdrawal management, risk of withdrawal from other substances, so if they're also using sedative hypnotics or other psychoactive substances, that increases their risk for severe withdrawal. And finally, social barriers need to be considered to withdrawal management. If they're in an unstable living situation, it's difficult to do outpatient treatment. So there are kind of two basic ways of approaching withdrawal management. One is to provide a predetermined fixed dose medication that's tapered over time. And for an outpatient setting, this is generally the easiest and probably the preferable way of trying to treat withdrawal. Symptom-triggered therapy is probably better overall, but requires somebody who can assess and then medicate the patient based on those assessments. And so this is much more difficult to do in an outpatient setting unless the person is accompanied by a professional who knows how to do these assessments. So next slide. So here are some medications. So benzodiazepines are really the standard of care for treatment of alcohol withdrawal. And this is because they're effective. They're generally well tolerated, although patients can develop sedation. So the three main ones that have been used in studies in the past include chlordiazepam epoxide, diazepam, and lorazepam. These are the brand names in the United States. So chlordiazepam epoxide and diazepam are both longer acting agents and are generally preferred in most settings. Lorazepam is a shorter acting drug, so it has to be given more often. It doesn't require hepatic metabolism, so sometimes we prefer that for patients who have significant liver disease. Although if you're doing this in an outpatient setting, you're probably not going to be treating somebody with significant liver disease. There are some other agents which can be effective in patients who have mild to moderate withdrawal. And these include carbamazepine, gabapentin, oxcarbazepine, and valproic acid. Sometimes clonidine is used as an adjunctive agent to help with elevated blood pressure, but it really shouldn't be used for treatment of withdrawal by itself. So the tool provides some examples of fixed dose regimens, and I'm just showing you one right here, which is the chlordiazepam epoxide dosing, and it gives you a few different options. The tool also provides similar schedules for diazepam and lorazepam. You know, it is generally helpful if monitoring can be done by a reliable friend or family member. You know, if the patient does experience over sedation, then you should probably adjust the regimen. Ideally, if you're doing this in an outpatient setting, you will be seeing the person either on a daily basis or perhaps touching base with them by telephone to check in and see how they're doing. And you can provide some, you know, instructions and adjustments depending on how they're doing. So if you do choose to use symptom-triggered treatment, which again is probably best for an inpatient setting, there are a number of tools that we can use to assess the severity of alcohol withdrawal. One is the brief alcohol withdrawal scale, which is a 5-item scale. Agitations, sweats, tremor, orientation, hallucinations, each graded 0 to 3. Again, the studies that have been done using this, it's been administered by a trained professional in a clinical setting. The Clinical Institute Withdrawal Assessment for Alcohol Withdrawal Revised, it has been around for a longer time. This is a longer scale, 10 signs and symptoms. Again, in the studies where this is used, this is administered by a trained professional. Another option is the short alcohol withdrawal scale, which is actually a scale that a patient can self-administer. So this potentially could be used in an outpatient setting where you know, patients given instructions on administering medication based on their score on the scale. But again, this is somewhat more complex than doing fixed dose taper. So here are some examples of symptom-triggered scales. Again, these are administered you know, based on the score. You know, they have the advantage of you know, flexibility, you know, providing less medication for patients who don't need much medication, providing more for patients who need more, changing the frequency of assessment based on the severity. So these are really the ideal for a monitored setting where a patient is being treated by healthcare professionals. So one important care consideration is Wernicke's encephalopathy. So this is an acute illness. It's seen in patients with alcohol use disorder and can be undertreated and missed. It should be suspected in any patient who is undergoing alcohol withdrawal treatment who develops confusion, memory problems, or difficulty with gait or coordination. A related condition, Korsakoff's psychosis, is a preventable dementia characterized by poor memory, but with relatively intact intellectual function, and generally occurs after Wernicke's encephalopathy. So these are conditions that are caused by lack of vitamin B1, and this is commonly seen among patients with alcohol use disorder. So these are some things to look for when assessing somebody with alcohol use disorder. And so I think this is important to recognize because really the treatment for Wernicke's encephalopathy is intravenous thiamine. And obviously this is something that would probably be best treated in an inpatient setting. Now for patients who have alcohol use disorder and there's no suspicion of Wernicke's encephalopathy, you can give oral thiamine as a supplement. For patients who are at high risk for Wernicke's encephalopathy, for example, patients with evidence of malnutrition or nausea and vomiting, you can give intramuscular thiamine in addition to, or as an option instead of intravenous. But really, you know, this is an important condition to look for, and really requires aggressive treatment if it's suspected. So finally, I think that it's important to always remember that withdrawal treatment is just the first step. So it's not the cure for alcohol use disorder. It's a process to help someone get through with withdrawal so that they can continue with ongoing treatment. So the goals are really to get them through withdrawal, as comfortable as possible to prevent the complications of alcohol withdrawal, and then prepare them for long-term abstinence from alcohol use. And this may include follow-up visits, participation in evidence-based and culturally sensitive counseling services, engaging with psychosocial recovery supports or mutual health, self-help groups. I would also add, medications, including naltrexone or others, can also help with this process. But really, withdrawal management should be part of a comprehensive care plan. It shouldn't be the only treatment that patients receive. So I think those are my slides. And
Thank you so much. Let me get my camera back on here. This was amazing. I know I learned a lot, and I'm sure a lot of other people did. I'm going to pull up questions from the chat here or the question area. So if you have a question and you haven't put it there yet, please let us know so we can have some conversation. One question is if the PowerPoints, if you will be able to distribute the PowerPoints.
well, everything that's in our slides is in the document.
There you go. So if you have the
I don't have a problem distributing the slides if that's helpful. That can be done. That's fine.
All right, wonderful. So hopefully everyone. Yes, please.
I was going to add, again, if you all have a chance to look at the document, look at the tool, you'll notice that it's really brief. It's not a long clinical practice guideline. It's a handful of pages with some template recommendations. And so the slides are great, but again, they are just screenshots from the actual tool. That's just how practical and how easily you could just apply it to day-to-day practice, just starting right now. But yeah, I think it'd be great if, I'd be happy to send slides or anything. We want you to use it. We want you to be able to have the knowledge and be able to begin making good assessment and treatment recommendations.
Thank you, Audra. And I don't, go ahead, Linda.
I was just going to add to what Audra said, which is we really designed this, and it truly was collaboration. We couldn't have done this without ICUDDR support and ISAP support, but it really is meant to be able to be printed and shared. And again, it's in English in its current form. We probably need to talk about whether we expand on that, but if you're at the very beginning of the process and you just want to have a meeting and a conversation about why this is important, the tool is not only brief and easy to read, but it really highlights what has to be in place at the local level. So again, whichever direction you come at this from, whether it's from the hospital direction or the community direction or operations management who's struggling with what's hitting your urgent care emergency departments, I think the tool can be used as a convening for the conversation of what needs to happen and how you can proceed.
Wonderful. And I was just going to say that, not all the folks have probably access to the tool yet, but it is on our website, and I think it's on ISSUP's as well, but certainly anyone, we can share it here. We really, to everyone's point, want it to be widely disseminated. It is a, tool that we're proud of and that we want in the hands of the people who need it to use it. And I love the editable, the template and being able to take it and make it make sense for your area. It's going to be different for everyone. So thank you. All right, let's see what else we have for questions. We have some compliments and kind words for all of you, of course. Under the current COVID circumstances, whether the outpatient and home-based treatment for alcohol withdrawal is a reasonable setting.
Yeah, I think it is. And certainly COVID is a factor we have to take into account. But there are some patients who it would be difficult to treat in an outpatient setting, and I think we still need to provide them with the services they need.
Can I add to what Darius had said there? I think perhaps this is a wee bit of an insurance policy clause. Is that the tool is not, instead of seeing if there is one available, a good practitioner. It is not a DIY type of tool that anyone can do, because in a way it's meant to help you think, help you explore, help you communicate and collaborate with your local network. From my own clinical experience, and I'm sure others would agree, is that there's never a clear-cut case, but once you do the right assessment, ask the right questions, usually there is an indication of what the right type of intervention should be.
I think, Alex, it's so important to acknowledge that. I think there are people don't understand how to make that judgment, and so we really tried to make that front and center in the tool, that even a good clinician is nervous with someone with a history of misuse, knowing, is this manageable? If you're not a specialist, if this is not your primary focus, if you do family practice and you're worried about misjudging what's required. And I think being able to build a team that feels competent and confident to make those judgments and to educate the community in how you start to think about these things just makes it easier for the services to be appropriately matched to the patient, rather than, and certainly I've seen this here in the United States, particularly in rural areas, but not only in rural areas, where fear of doing the wrong thing means we don't do anything. And I hope that the tool gives people some confidence that they know what they need to watch for to make a decision and mitigate risk to the patient, as well as protect the system and the services, and really allow people to gain recovery earlier in the process, because we know outpatient can work if we can get more confident with it.
Great. Excuse me. So I have the question. This is a great presentation. What do you recommend for interventions in countries where thiamine 4 is not readily available?
Can I start, Darius? Because I'm not surprised with that question. That's a question that's asked in every country, actually, and because the evidence seems to there seems to be two schools of thought around this. But what I would suggest, and again, what I had to do in my clinical environment, which is in Scotland, is to ask pharmacists or toxicologists, whoever is responsible, to guide you around what one should do when there's a suspicion for pharynx encephalopathy, or if you are planning to do administer thiamine. It's a tricky question. Even within Scotland, different health boards had different guidance on this. Certainly, I wouldn't encourage you to straight away provide intravenous thiamine with all its risks, etc. So I'm doing the psychiatry bit here, is that I'm certainly not answering your question, the person's question, but certainly encouraging the person to talk and discuss and make sure what is the the recognized and therapeutic indication for this. Darius, sorry.
Oh no, so I agree with all that. I mean, I think that I work in a unit where we do alcohol withdrawal treatment, and we provide everyone with oral thiamine, but it's pretty rare that we've felt the need to give intravenous So I think it's certainly not a common issue, but it's something we need to be conscious of because the results can be pretty devastating.
So maybe you've already covered this, but this is related and I just want to make sure. So in Malawi, we have just started a program of improving management of AWS, challenges lack of the I don't know how you pronounce that, thiamine. We are using oral thiamine as only alternative at present. What are your thoughts on this approach? And it sounds like, Darius, that's what you're using as well. Okay.
Yeah, I think for general prophylaxis, I think that's fine. Yeah.
Great. Okay, about adolescents with AWS, how do you balance the treatment options for underage drinkers? What are the possible side effects for this group?
You want to start, Darius?
Well, I guess I'll start by saying that I don't treat adolescents personally, but you know, I mean, it's unusual for adolescents to have, I mean, even for very young adults to have severe withdrawal. So usually people have to be drinking heavily for a certain amount of time before they get to a stage where they have significant withdrawal. So, but I'm sure it's possible, and I think that you would probably treat similar to adults, if I guess depending on you might adjust the dosages based on their body weight, but I don't think that you would necessarily have to do things much differently.
I had a couple of experiences because in Scotland, an underage or non-adult is 16 years old. I know it's different in different countries. And so we tend to, depending if the person is able to consent and shows ability to, do a good, well-informed consent process, then we shall do. And we had alcohol withdrawal with people ages 14, but not below that. But the trick of it all is not the age, is not the gender, it's not, the social situation here. It's the trick is the assessment. If you do a TARA assessment and the clinical indication is showing that the risks of not introducing or managing withdrawal is increases the risk, then if clinically you feel following a TARA assessment you are increasing the risk of harm if you do not intervene, then clinically you have a duty to intervene. I hope I made myself well, but based on a very thorough assessment of the clinical justification to intervene. And I had to intervene for about 10 cases in my professional life.
So are there any contradictions to using benzodiazepines?
Not really. There are no real contraindications that I know of. Occasionally, I may run into somebody who says they have an allergy to a specific one, which is pretty rare. But I would just use a different one. I mean, I think that for patients who have significant liver disease, you have to be conscious of that they can become over-sedated. For an older, frail person, again, I would be more careful about dosing and side effects, but there's no contraindications.
Pharmacologically, perhaps.
I know. What about with methadone?
Yeah, that's what I was going to say. Pharmacologically, okay. no indication, but again, following an assessment, and this person is a polydrug user or is in treatment with other sedatives, not just methadone, antidepressants, antipsychotics, experiences comorbid substance misuse and mental health and or physical health problems, is going back to what Darius has put in his second slide, is that would be an inpatient treatment. So again, the person might be dependent on benzodiazepam and alcohol. What should one do? So there are different specific complex cases, but you take that on a case-by-case basis, because there were moments when, you know, they were polydrug dependent, not on any treatment, injecting heroin, and I made a clinical decision to initiate, because somehow you need to start from somewhere to determine what's, and move the person, you know, into some journey to recovery or harm reduction. So case by case, and I suspect, again, going back, not every case is different, and we shouldn't sort of make clinical judgment on one particular case that would be replicated to other cases.
So yeah, fair number of patients, fair number of patients that we treat are patients who are on methadone, and so we do treat them with benzodiazepines, although we are monitoring their symptoms and we adjust the medication depending on their response. So if they become sedated, we come back on the medication, but you can use benzodiazepines in somebody on methadone.
Interesting, thank you. Audra?
I was going to add, because it comes up here in the clinic I work in, that there are times where the prescribers that I partner with do not prescribe benzodiazepines due to the concern about it being misused or a history of use. And so the tool addresses this, and there is a protocol for a non-benzodiazepine medication-assisted alcohol withdrawal approach. So you can look at the tool and see how we detailed that as well, in case benzos are not indicated for after the assessment that you conducted.
Amazing, thank you. Linda?
I just wanted to add, like, part of what you see in the tool is also how you can monitor, and I can't underscore enough the importance of training your clinical staff. I mean, you need prescribers that understand and can manage, but by building outpatient services, we begin to build the network or the safety net for those who have more severe alcohol withdrawal syndrome. I mean, part of the problem is this misconception that somehow if you manage withdrawal, we discharge and it creates a revolving door. And what we need at the community level is to build understanding, to educate families and communities about the risks, so that people are flagging alcohol misuse and issues before they get to be severe. But also building the outpatient pathway creates a step down for those that do need to be managed in a more acute care setting, but have to go back to their communities. I mean, at some point, withdrawal management is done, and there's other stuff that has to happen to support the individual and their family and community. So it's a bigger package than just withdrawal management, but certainly mitigating the risk of death and morbidity from this is part of the motivation.
Absolutely. We have tons of questions. It's great to see people so engaged. Thank you all. This one says, great lessons. Can the tool be incorporated in a study PhD for prediction of alcoholic relapse? You can think on it. You can get...
What was the question? Sorry, I was trying to.
Can the tool be incorporated in a study? I assume this person is going for their PhD for prediction of alcoholic relapse.
Well, my initial comments is, you know, never say no to a potential PhD student who's really keen to do any research. However, you know, you need to make sure that the tools you're using are measuring the symptoms, or, you know, that you want to measure. So if you're measuring dependency or severity of dependency, there are other tools rather than using the tools for severity, even though proxy, but not necessarily. So this is a bit academic, not necessarily, it's not a correlation. Severity of withdrawals is not necessarily directly correlated to severity of dependency. but by proxy, you can assume that people who are severely dependent, severely withdrawing, should be severely dependent. So that's very academic for a potential.
So what you're saying is I should give them your number.
Email better than number. It will cost them a lot of money. Yes, please do.
This question is, what is the role or importance of psychotherapy in this respect? And I think this goes back to what Linda was saying, how the withdrawal is key to keep people safe. And obviously, it's very difficult to provide psychotherapy to a patient who's no longer with us. So, you know, we're looking at this as part of the continuum, but I don't know if any of you want to add anything to the importance of psychotherapy with this.
Darius, I'm looking at you. I'll start, but you know, as a psychiatrist, psychotherapy, psychosocial support, counseling, motivational interviewing is paramount to any pharmacological treatment, not only on alcohol or alcohol withdrawal, but for depression, for anxiety, or else the drug, the medication wouldn't work. So that's my take of this. It's important. It's not an option. It's a necessary to have psychotherapy with any type of interventions.
All right, wonderful. This is a person joining us from Indonesia, and they asked, are there any other methods for treating outpatient besides using medical therapy? Considering that in Indonesia, the use of medical therapy is very limited to be given in relation to professional and legal regulations. Audra?
This is something that we discussed a lot as we were working together, and our hope is that this tool could be used perhaps as a way to advocate for or suggest changes in a system to demonstrate that, and I know it can be complex, but it could be a beginning to show what does work and is recommended, and is there a way to get change in your legal system, a way to get change in your healthcare system. Even just a small change could lead to bigger change. And I know my colleague Linda is working on a lot of infrastructure development and systems work with those same types of questions, even in the US. But perhaps this tool could be used to start those conversations and demonstrate evidence-based practice that could be more helpful to your country.
So someone is messaging us from Turkey, and of course, you know, this is a great opportunity to just give all of our thoughts and send, you know, kindnesses and charitable thoughts and anything that we can, any way we can be helpful to the folks in Turkey. This person says they haven't seen the tool yet, but their question is about what we should understand by outpatient setting, since that differs from country to country. For example, in their country, all of the outpatient settings have physicians, especially psychiatrists. Is this tool suitable for centers which do not include physicians?
Yeah, I mean, I think it could be used in settings where you have, I guess, you know, advanced practice clinicians. I guess it's different in different countries. We have, you know, nurse practitioners and physician assistants in the United States who do these kinds of, take on these kinds of roles, and they certainly can do that. So it's certainly experience and training helps, you know, in for any clinician, whether they're a physician or otherwise.
To extend to that, what Daria said, you know, so that includes primary care, community care, and anything that does not have a bed in a room, so to speak, you know, different. But it's also important, it's relevant for not just medical prescribers, but also non-medical nurse prescribers, non-medical pharmacy prescribers. Different countries have different or a varied number of prescribers who might be working in the community. So it might be For example, I'm just giving you an example. A health visitor, so someone visiting someone's child. Some countries have that service. When a child is born, notice that the mom might have alcohol-related issues, might be presenting with alcohol withdrawal, and this health visitor has been trained as a prescriber and is able to use the tool for that purpose with one's own network. So there are different communities. That's a very good question, actually.
It's a really, I think we worked very hard to not be country-centric, but by using terms like prescriber or non-prescriber, we didn't try to define scopes of practice because those are different depending on where you are and what the system looks like and what licensing and regulatory landscapes are like. But I think the tool, once you see it, and again, it's in English now, we need to think about how we expand that. But I think it can be adapted to your practice setting and to the qualifications and the way your system works. And to your Darius, to your and Alex's point, you know, sometimes pharmacy and chemists have a bigger role. Sometimes advanced practice clinicians have different titles and different scopes of practice. And there are opportunities, I think, in using the tool to sort of say, okay, how could this look in our context?
And I'll just say that I'll take a little credit, I guess, that ICUDDR would not really support and implement so widely something if it wasn't adaptable to different regions and areas, and you have all done an amazing job with that. And that's a key piece of what we do, to be, you know, to have things be appropriate for low and middle resource areas and not assume certain, you know, that, oh, well, everyone has a psychiatrist or a psychologist or a doctor or whatever. So this is well in line with that. I'm just going to do one more question because we're coming up on the hour. I think this is a really important one. This person says, I'm an addiction professional in counseling. How important is for us to know the psychology or mental status of a recovering addict before we apply the alcohol withdrawal management tool? So getting at the issue of co-occurring disorders. Linda's smiling.
You know, you can't treat dead people.
Exactly.
I'm sorry.
Yeah, no, that's
So
what I
defer,
said.
I defer to my clinician colleagues, but to me, the biggest question is this person suffering severe withdrawal, and do they need immediate care, or can we manage this in an outpatient setting? And that is the first question that has to be answered.
Yeah, and in a way, you know, being a counseling practitioner or a psychiatrist, etc., I think we are duty bound, going back to, you know, a presentation around the global alcohol action plan, that we're duty bound to be trained to identify issues and problems, and we cannot not say this is not my job, this is someone else's job, etc., or try to, you know, break a human condition into bits and pieces of care and choose the one that you feel comfortable about. I think gone are those days.
And I'll just add, I think most of us are aware that typically when we're encountering somebody who's got severe alcohol use disorder, is at risk of alcohol withdrawal, very often, not all the time, but very often, there are co-occurring trauma, anxiety, depression, relationship issues. That's often the alcohol is also symptomatic of so many other things. And we have to take that whole person approach at some point. But initially, when alcohol withdrawal is a risk or the concern, we really have to triage that and stabilize that, and then start working on all the other elements that need to be attended to. That's how we typically approach it.
Great, and Audra gets the last word. Thank you so much. I'll just mention again that the webinar recording is going to be available for all of us in English, Russian, and Spanish, which I think is so exciting and wonderful. And I will commit to trying to get this tool translated into different languages through whatever means ICUDDR has available. So thank you again to our partners at ISSUP and ISAM, and thank you to your amazing presenters who did not only an excellent job with the webinar today, but have put so much work into this tool and really clearly want to have an impact on communities, and that just, I feel honored to be part of it. So thank you all.
Thank you.
Thank you.